Okay, hello everybody. Welcome to the Investigations and Therapeutics of Emotional Wellbeing. I'm Robyn Puglia from Regeneris Laboratories, and I have with me today Dr. Rajendra Sharma as our guest. Hello, Dr. Sharma.
Hello, good afternoon.
Dr. Sharma is a leading integrated medical doctor who utilises conventional, functional and complementary medicine. His special interest is working with chronic disease and its underlying causes, and he has a particular interest in chronic fatigue syndrome and ME, cancer and other complex and difficult conditions, including poorly responsive psychological and psychiatric conditions and its association with undiagnosed thyroid, B12 deficiency and nutritional deficiencies. So he focuses on optimizing health through nutritional and non-drug medicine, and his experienced and highly respectable career includes positions as medical director at the Hale Clinic and the Diagnostic Clinic, and he was also the past secretary and treasurer of the British Society for Ecological Medicine, where he was involved in ecological health screening, including metal toxicity, food allergy, pollution, etc., and also treatments. Dr. Sharma is considered by many as the family doctor, and as a generalist, he works with all medical conditions. He's the author of the Family Encyclopedia of Health and the award-winning All You Need to Know Healthy Aging book, Live Longer, Live Younger. He also works with many CAM practitioners and nutritionists, and he offers medical support and guidance and provides content and comments on topical issues to blogs, journals and popular magazines. He had a 10-year slot with regional BBC radio and has appeared on TV, in the media and expert panels extensively, and I'm really delighted to be speaking with him today on the topic of emotional health and well-being. So welcome, Dr. Sharma.
Thank you very much.
I know that today's webinar is going to be really interesting, and I'm happy that you could join us for it. Before we get into the nitty-gritty of neurotransmitters and neuropsychiatric issues, I'd actually like to ask you a couple of semi-personal questions, if I may.
Fire away.
So here in the UK, there are actually precious few MDs who have been practicing the broader scope of integrated medicine for very long. We've got a new wave of young docs coming up now who are really excited about lifestyle and functional medicine, but we also have this small community of fairly brave doctors who have been sort of below the surface, serving the patient population and trying to avoid maybe making waves for colouring outside of the conventional lines. So you are one of those doctors. You've been swimming in this pool for a really long time, and so I've got a couple of questions for you. The first is actually why you became a medical doctor in the first place, and the second, I'm always interested to know how you made the transition from conventional medicine to integrated medicine, because there's always a story there, I think.
Okay. Well, I wanted to be a film director.
Okay.
After I wanted to be a fireman, or before I had wanted to be a fireman.
Mm-hmm.
But my dad said to me, why don't you go off and get a medical degree? Because if you don't want to do it, you can always go into film. And I said, okay, fair enough. So off I went, and I trotted along to medical school because my dad was a doctor before me, and my granddad was a doctor before both of us. And it was in the blood, I suppose. My dad became a surgeon, a pediatric surgeon, and then switched to complementary medicine. He'd come over to the UK. He had been trained in India initially, and he got a degree in midwifery, and he seemed to be very knowledgeable, but he still went back to his roots. He wanted to work with curative medicine rather than palliative medicine. And I think that the simple difference between functional medicine and complementary medicine against conventional medicine is really looking for underlying cause of condition and trying to restore function. At the end of the day, if something goes wrong, I use a hand gesture here, if something goes wrong, it's because that thing has become dysfunctional. Mm-hmm. Conventional medicine tends to put a drug on top, tries to get rid of the symptoms, make us feel better. It may, if let's say an organ has failed, keep us alive. So it's certainly a wonderful thing, medicine of today. But what seems to have been lost is that ability to restore the function. And so functional medicine, which is a lovely term, I think, tries to put both together. And my dad was doing that when I was growing up, and I was seeing people get better from things they shouldn't get better from. So when I went off to medical school, I was fairly confident that I'd be taught much the same but I wasn't really. I was taught a lot about how to take people out of pain, get people with asthma to go off and win Olympic medals, but it didn't actually resolve the underlying cause of the pain or the underlying cause of their inability to breathe. So I came out of med school, did a very short stint in the NHS, and was fortunate enough back in the mid-80s to be able to join my father's practice. He worked with 2 other doctors with the same sort of ilk. And that was very much the first real wave of interest in the UK. So I was brought up with an interesting background and quite a considerable amount of expertise. My dad sadly only lived for a couple of years after I started working with him, so I hadn't got the experience. So what I did was I turned the practice into a clinic, and that clinic grew, and I was working with about 30, possibly 40 different practitioners, simply because I had a vague and then learned idea of what alternative medicines could be used for what condition. That then proceeded to my becoming part of the Hale Clinic, where I worked with over 130 different practitioners, and I and a colleague there referred as we felt necessary. So effectively a hub in the wheel. And then the term functional medicine came along, and I think that's the most accurate and most appropriate, because it allows us to look at how a cell functions, how tissues function, how organs function, and that leads us to trying to get the body to restore its own health. Sometimes it can, and sometimes it can't. But that's my path to so-called integrated medicine.
Fascinating. So you literally learned it at the knee of your family.
Yeah,
Father. That's a great story. And what a great introduction to medicine in general, that you went into it thinking differently.
Yeah.
Instead of having to come out the other side of medical school and then have an awakening kind of thing.
Yes. Yes. Very, very, very good way of putting it. Thank you.
So look, the science of emotions is a really interesting one. You know, traditionally, I think it's been the purview of either psychology or psychiatry or neurology, with everything being compartmentalized and separate. But of course, we now better understand that everything is interconnected and quite dynamic. You know, that the human body is a dynamic and interconnected system. So when we're dealing with a case that involves emotions, or it involves a psychiatric diagnosis, or that it involves a functional GI disorder, for example, you know, that there's a lot that needs to be taken into consideration rather than just thinking about things in a more narrow way. So Dr. Sharma, could you start by walking us through how we even feel emotions in the first place?
How we feel emotions. Okay, well, let's make the initial assumption, which most of us do, that the mind is actually in the body. There is an argument that suggests it might be outside the body.
Not just cut off at the neck.
Leave Rupert Sheldrake and his theories aside and look at this from a more scientific point of view. External stimulus, vision, sound, taste, touch, come to us, and our nervous system recognizes the stimulus. Nerves are activated, which travel effectively and eventually, we're talking milliseconds, of course, to the limbic system, which is a part of the brain that deals with emotion and memory. It does other things, but let's stick to the relevant parts. And that stimulus is then modified and then transmitted to various parts of the brain that have to recognize it. And it's transmitted through electrical impulses traveling down nerves. Those nerves are dependent upon the structure of themselves and also upon the chemicals within the nerves. Nerves have synapses where they can pass information across a little gap, and this gap is filled full of neurochemicals or neurotransmitters or neurohormones. These are all much the same interchangeable words. They hit another nerve that travels down until it gets to that part of the brain that's relevant to that stimulus. So if I'm listening to a piece of music that I like, then it'll go through the auditory system. If I'm looking at something that I'm enjoying, a pretty flower or film or something of that sort, it'll travel down through the optic nerve to the limbic system and off around the brain. And I should respond based on those impulses reaching a healthy area of the brain that will say, oh, that looks nice, that smells nice, that sounds nice. And if everything is intact, everything's working perfectly. Problems therefore arise when we have problems with any of those issues. Can we not sense? Are we unfortunate enough to be blind or deaf? Do we have neurological issues that are stopping us from smelling? Is there a problem with the nerve itself, so it's not transmitting? Are there areas within the synaptic clefts that suggest that chemicals that are there are not transmitting correctly? When one nerve sends out an impulse via a chemical messenger, is the receptor there, or has the receptor in fact been blocked by something? And then, are the next nerves okay? And then we get to the actual area of reception and recognition, and has that been damaged? Are there toxins there, infection there? Have we had some damage from tumor? Blood flow, loss of blood flow. So all of these issues come into play when talking about what actually happens. And it's through those particular pathways that we can try and influence the physiology.
So when you're breaking down a case, you're essentially having to evaluate each one of those to see if there is something present that needs to be removed because it is removed or addressed because it's preventing healthy function, or something missing that's required for that function to occur in the first place, or for healthful messaging all the way along the pathway.
I think if we're talking from a physiological point of view, that's absolutely right. The psychological aspects are very important too, because our consciousness and our subconsciousness, and indeed our unconscious aspects, are all interfering with how we relate to the stimulus that gets to those areas of reception, and also the response centers. A piece of music that I like may make somebody else cringe. That's going to be beyond the concept of the transmission through the nerves and the synapses. That's going to be perception. And that is a completely different aspect. So yes, we as practitioners and physicians have to look at the structure and how everything is working. But if we don't look at the perceptive aspect, we miss out on perhaps 50, 60, 80, 90% of the principles of emotional behavior. One person's ceiling is another person's floor. And indeed, what we may see as something unacceptable in one society is perfectly acceptable in another. So I mean, I think that's a huge part of our talk today, is going to be not to forget the psychological implications of any emotional issues, be them depression or anxiety, whatever. Leaving one part out and not the other completely removes our efficacy, I think. It's true, you have to be truly integrated here in the nervous system and the emotional in an emotional situation than you do probably in any other part of function of the body.
It's true, I've never really thought about that before, but it's that sort of real overlap between the right-brained, emotional, more ethereal side, the non-tangible side of things, and the impact that has on the body, overlapping with the neurochemistry and the physiology. And those two are so deeply interconnected in this area that they are. You can't really work with one and not the other, or you can, but you won't be as effective, for sure.
Correct. So it is as important to reflect upon a psychological examination in any consultation as it is upon a physical one. And perhaps that's more related to being a physician or a doctor, when dealing with somebody across a desk where examination may not be quite so relevant, and you're taking the history. That focus in on the psychology is so important, and it's so important to go back in the history. If we look at all our emotional aspects as the branches of a tree, and we have a trunk below it, and below that we have the roots. And if you have, let's say, a traumatic childhood, let's pick on an alcoholic mother. Well, that's going to influence how you will behave towards female who is drinking. If you have a brutal father, it may be the other way around, of course, but if you have a brutal father, what happens? What's your relationship going to be towards a male who appears angry? Well, our memory cells, little parts of the ethereal concept of emotional well-being, allow us to go back in time, and bearing in mind that our nervous system develops from our roots from when we're little through probably all our lives. I don't see any reason why the nervous system and its subconscious emotional aspect would change just because we've grown up. Certainly, I don't think there's a year has gone by where I wouldn't look back and say I would emotionally deal with a situation differently from the experiences that I've had. So when we think about it that way, we must understand that a traumatic childhood, and there are very few of us who won't have memories of trauma of some sort. So it doesn't really even have to be a traumatic childhood, just a childhood will be leading us to form levels of adrenaline, levels of happy juice, serotonins, motivation, dopamine, and so on. But these are going to encourage the growth of receptors in these different parts of the body and the brain. So if you happen to have been brought up with a lot of adrenaline, you're going to have a lot of adrenal receptors, and your body's going to consider that a norm. And this may then lead to a small amount of adrenaline hitting a vast number of adrenal receptors, because that's what we were thought or taught by our nervous system was the norm. So we're just going to keep repeating that and keep reproducing them. So people can grow with a normality of anxiety. And it's very frequent if you ask the question of your patients, or if we're not just talking to practitioners and we're talking to the public, look back, was mum or dad an anxious, nervy type? Would we have learned that that would be a nice, safe, adult way to do things, and would our nervous system have adjusted to do that? The relevance of this, of course, is that one person's norm does not make it an abnorm at all. Because if you happen to be an anxious type, and that's what took you through your youth and took you through your formative years, it might be perfectly normal for you. And without it, you would actually be abnormal. So trying to define normal and abnormal in the nervous system is a very difficult one. And that leads to quite a lot of variation in how a physician or a practitioner might look at somebody who is depressed or not depressed. And of course, there are different types of depression. So when we when we have a first meeting, we must take a very in-depth history and go all the way back. And it's not just about the physiology of the nerves. It is to a great degree, what happened then to make the nervous system behave in this way?
Fascinating, really. I mean, it's sort of, it's almost a joke that, and I mean, it's almost a joke that people discuss amongst themselves that you never really get past high school in life. You know, that the things that you were struggling to overcome or that you were dealing with at that time, they're the same responses, they're the same things that you will be responding to and trying to overcome in your 30s and in your 40s. You know, it's that if you never had that bicycle and you desperately wanted it because all of your friends had it when you were 8 or 9 or 10, when you see that bicycle and you're 45, you know, it will create a big emotional response in you in the way that it absolutely wouldn't to the next person who either didn't care about the bicycle or had the bicycle and just didn't have that same childhood experience.
You wouldn't expect the branches of my analogy of a tree to differ in its bark from the trunk. So as we grow from that sapling, it is very unlikely that we will see much different to that from which we have seen.
You're not, unless it's been grafted with hard work, you're not going to have apple branches growing out of a plum tree.
Yeah, you're adding to the analogy here.
Yeah. I'm quite good at painting pictures to go along with my stories, it turns out. So then, in practice, like when you have a patient that comes to you in clinic, what are you looking for within that history, or within the test results of the blood chemistry to determine if there is an emotional or a neurological issue that's underlying a described presentation? So fatigue, for example.
Yeah.
And part B to that question is, what are some of the underlying contributing factors that are also red flags for you when someone presents with an overt issue? So if they're actually presenting with depression or with anxiety. Can you talk to me a bit more about the investigations and the things that where your brain goes in clinical practice?
I think we've covered to a good enough extent the psychological aspects, and I'll just reiterate that in one sentence again, which is it is so important to make sure that you've established if the patient has recognized, or if you can recognize an emotional issue that needs to be faced, because you can do so much with natural medicines, with functional medicine, with nutritional medicine, with lifestyle changes. Exercise has a profound effect on emotional well-being, but it's all rather irrelevant if you aren't getting to that root cause. And you do need to establish within your own training whether or not somebody needs a psychologist or some sort of psychotherapeutic or psychospiritual therapeutic avenue. If you don't do that, then I think a lot of what we might try and do won't work. And I think one of the big problems that we all have, whatever avenue we've got to in healing, whether it's through doing medicine through medical school, or functional medicine, or nutritional medicine, or acupuncture, or massage, or Reiki healing, whatever it is, we don't really get the training in the history taking unless we do psychology. If you do psychology and or psychiatry, well, no, perhaps not even psychiatry, because this is an end point of a medical training. But if you are a psychologist, you often don't have any physiological training, and therefore, either way, whatever the training is, we don't necessarily get to see and understand the methods by which we need to make sure somebody sees a psychologist or follows some pathway in that sense. Now, that done, we have to do the physical exam, because if we've got a story of nutritional deficiency, of toxicity, of emotional status changing after infection, and we don't spot that within the history, again, we can travel off down the wrong path. And I think that to a great degree, a lot of conventional physicians, given 7 to 10 minutes with a patient, may miss the fact that the patient had a big welt from a tick bite prior to their emotional status dipping, or they've worked for so long as a painter decorator, and they have not paid attention to aerating the rooms they're in, and that we've got the potential for toxicity from a range of different chemicals that we're well aware of. We were very aware until lead was taken out of our society, taken out, where lead became recognized as a toxin and was reduced, taken out of our petrol. We paint less with lead paints. We don't live in lead-lined rooms anymore. But whilst we were inhaling lead, we were living with lead, we were absorbing lead, and that directly affects the nervous system. It can create psychological as much as it can create physical problems. But we're faced with, depending on what you read, 3,000 to 80,000 chemicals a day. And those of us that don't detoxify well, where are those chemicals going? And we've got all this fun in the news at the moment of this plastics enzyme, this enzyme that will break down plastic and resolve all the world's plastic problems, of course. Well, if we bear in mind that we grew up with plants and herbs, we have got enzymes that deal with those. But we don't have enzymes that deal with man-made products. We haven't had to evolve with them. So we are dependent upon the ability to break down man-made toxins through enzymes that may only be dealing with natural compounds. And a lot of us don't do it well. We have 6, 7 pathways, depending on what you look at, major pathways of detoxification. Some people may not methylate well. I think we'll talk about that a bit later on if we get a chance. Some people may not acetylate well, some people may not sulfate well. And if you are genetically predisposed, which was an advantage to get to where you are today, if you lack certain elements of your detoxification capability, you're going to build up toxins. And if those toxins are enough to disrupt membrane layers, gut membrane, the blood-brain barrier, if we start looking at these compounds actually getting into the nervous system, attaching to receptors, acting as neurotransmitters, then of course we start to run into problems. So good history. You get the history and you got 90% of the diagnosis. Yes, physical exam for those who are trained in doing that. It's useful to be able to know how to do a brief neurological examination. A lot of people will, with neurological diseases, have associated depression. Many people who are ill have associated depressions and anxieties. You need to know whether that's sitting there. It's all very well saying, well, we're going to deal with your psychology because we're talking about your emotions because that's why you've come to see me. But if that person's got a dropped foot or is shuffling gait or has a gentle pill rolling attitude to a hand, you've got to look for Parkinson's. You've got to look for other diseases of the nervous system, because the same chemicals that control movement and control a lot of our autonomic nervous system have an effect on our emotional well-being. So the physical exam is important. Going into testing, which we'll talk about, I'm sure, is extremely important. But picking the tests becomes quite an important aspect if we go down that path.
So from a depression perspective, I'm just using that as an example, do you differentiate between somebody who has, so somebody's come to see you, they have a diagnosis of cancer, a big scary diagnosis. Do you differentiate between somebody who is depressed because they have had a very negative, pessimistic outlook given to them because of the diagnosis that they have, and this a similar person who has had therapy, let's say, and they're depressed as a direct result of the impact that the therapy that they've had, let's say radiation therapy or chemotherapy, has had on their, it's a response to the inflammation? Or do you differentiate with the depression? I appreciate that functional medicine treats the person as a whole, but from a depression perspective, those two people both have cancer, they're both depressed, but do you?
Yes, I think I see what you're asking. I'm going to perhaps deflect that slightly.
Question.
There are so many different definitions and so many different subdivisions within, as you picked on depression, as there are in types of anxiety and types of psychosis, etc. Put very simply, we have divisions. There's endogenous and exogenous depression. I'm going to make that even simpler to understand, I hope, by talking about reactive depression. My cat has died. I've been given a serious diagnosis, to which a normal response should be one of anxiety, sadness, depression, and we go through those different stages of grieving. We go through those with a piece of bad news. It doesn't have to be the loss of a loved one. So all those different emotions, whether they are acceptance or denial, whether they are anger or fear, we still have chemicals attaching to receptors, making all that happen. Now, if it is reasonable, my cat has died, I'm sad, you can classify that as a reactive depression. You're reacting accurately to something that's happened. The problem lies, for many, in those where there is no obvious reason. And we end up having a depression despite living in a lovely house, having plenty of food on the table, dealing with our relationships well, having everything in place, and yet we're still sad, we're still down. Now that is an endogenous depression, endo, inside, as opposed to exo, outside. Endogenous depression is created by some failing within the nervous system. And it goes back to that recognition, the nerve transmission, the synaptic health, the receptor health, the neurotransmitter levels. And so the big division is reactive and endogenous. The subdivisions of that are rather dependent upon what else may be going on. And that again goes back to the history, because somebody whose cat has died, but they own a cattery, they're going to have a completely different perception to somebody whose main companion was their cat. So we have to again go back in the history. So I'm going to keep coming back to that because
no, please do, because it's so important that taking a thorough history.
Know your patient. Get to know the ins and outs of their emotional tree trunk and roots. So yes, I think that recognizing the underlying factors as well as recognizing the trigger points is so important.
Okay, so to know what to do, we have to know what we're dealing with. So some of the things I think that we need to consider include, and correct me if I'm wrong here, what's going on within the nervous system versus, or perhaps as well as, what is actually influencing the nervous system. So you've described the steps of the neurochemistry of emotion, and you've also talked about some of the things that that externally have an influence, history. But what else are we? If you were to make a mind map, what are the other things that you're considering that affect the nervous system outside of childhood trauma and bereavement?
Well, let's move on in a bit more depth into the physiology of the nervous system. I've talked about neurological structure. I've talked about neurotransmitters. It's very important to understand their structure. We make most of our we make all of our neurotransmitters, I think it would be fair in saying, through and from amino acids. Without the right proteins, without the right digestive capability to get those proteins down to amino acids, without the minerals and vitamins necessary to transfer required molecules from foodstuffs onto the amino acids to convert them. You don't turn your tryptophan into serotonin, you don't turn your tyrosine into dopamine, then of course you end up in trouble. So having a very good understanding of the breakdown or the build-up of neurotransmitters is extremely important. We have to look at other things than neurotransmitters. What do estrogens and testosterone and progesterone do? Estrogen is a very excitatory hormone. It's balanced by the more calming progesterone. In boys, it's testosterone. Progesterone has its effect to counteract the overactivity of testosterone. We have to look at chemicals that may come from other areas. Before I move on to that, let me make sure I talk about thyroxine. What an important hormone for our emotional well-being. Adrenaline, of course, which is a neurotransmitter, is our stress hormone, and it's balanced by cortisol, our stress coping hormone. If we have too much adrenaline in the system, we would feel it through excessive heart rate, higher blood pressure, throbbing, tension in the muscles, headaches. The cortisol in the system should be trying to counteract that, or at least create a balance. In the brain, you're looking at your calming hormones, the serotonins, for example, or serotonin, for example, which we would look at trying to stop the adrenaline response. But we've also got exogenous compounds that come through. These can include compounds that are made by the microbiome, the bowel flora, highly underestimated area of concern. We've got so many effects of the bowel bacteria influencing our neurological system that it's quite surprising that a lot of conventional medicine doesn't actually work on blocking or interfering with the compounds made by the gut bacteria. We know that gut bacteria make neurotransmitters. They make other hormones. They make estrogens, testosterones, progesterones, or mimics that can attach to receptors that influence our emotional well-being. We don't have a healthy microbiome. We don't break down our fats very well. And certain short-chain fatty acids are neurotoxic. They're actually damaging to us. We know, particularly through the work of psychoneuroimmunology, a whole huge branch of science, which by its name, it does what it says on the tin, psychoneuroimmunology. If we put aside the psycho bit, which we've discussed, and just look at the neuroimmunology, it simply means that if your neurology isn't right, your immune system isn't right. Mm-hmm. Now, the bowel flora, as we know, has a huge effect on immunity. It is a primary first-line defense itself. It stimulates secretory IgA in the bowel wall. It lines the bowel wall to stop bad bacteria, or good bacteria, frankly, getting into the bloodstream. It stops food particles, undigested food particles coming through. Food particles can act as neurotransmitters, therefore affect mood quite comfortably. Mm-hmm. We've got a range of different gut health issues that will occur if the microbiome fails or becomes dysfunctional. If the gut isn't healthy, one of the big problems is increased intestinal permeability, or the leaky gut syndrome, back to allowing lots of things to travel into the bloodstream, attached to receptors. We've got a range of problems directly, but we have it indirectly because of autoimmunity. If you have a leaky gut, you're more likely to trigger the body attacking proteins. If those proteins look like our own proteins, we end up with an autoimmune trigger. Autoimmunity is well researched and is very much a part of the blood-brain barrier issue. The blood-brain barrier is a very thin layer, prevents things crossing into the brain unnecessarily. Do you want to say something there?
I'm just going to add in a diagram that I think illustrates what you're talking about here.
There we go. Yes, yes, absolutely. So, a quick physiology lesson here. We've got the we won't go too deeply into it because we don't know the depth of our audience. This particular diagram is showing what should be a nice bonded layer of epithelial cells, where you can see these things called intact tight junctions. The tight junctions are meant to allow certain things through, but they are not meant to allow a lot through. Most absorption will actually go on through the cells themselves. Now, underneath that, we have antibodies, our body's defense mechanism. And most of those will be doing a good job attacking things that they should attack as they try and get into the brain. But if some of those compounds look like our own tissues or our own proteins, we will end up with a problem of molecular mimicry. And this is where the body attacks what it thinks is a bad thing, but is unfortunately something that we have in our cells. So in other words, if we have a protein ABCD, which is bad coming in from the outside, but we have a protein ABC lining a heart muscle or a kidney cell, then the body may attack the ABC thinking that it's ABCD. When we get too much of that autoimmune response or reactive antibodies they've got here, but where they're attacking themselves, we start potentially to run the risk of attacking our own neurons. But that in itself is a tricky problem, and we can come on in a little while perhaps to how we can recognize blood-brain barrier issues and how to treat it.
There was a really interesting study in 2015. It was Karazi and Vojdani, 2015, and they did it was 400 participants in the study, and it was random samples from people who had given blood, and they took healthy, so they chose healthy participants, and they were screened for existing diagnoses, hidden, chronic infections, anemias, that kind of thing. So healthy participants, and then they tested that 400 subjects for antibodies to gluten, or actually antibodies to wheat and gluten, and antibodies to various different dairy proteins. And they found 17 to 20% of that healthy population had antibodies to either wheat and gluten or dairy. then they took the people who were antibody positive for foods and they tested them for antibodies against neurological tissue. And they found that fully 50% of the people who were reactive to dairy had, actually it was about 50% in both groups, but the people who were reacting to dairy very strongly had antibodies to myelin basic protein and myelin oligodendric glycoprotein in that study. And the people who were reacting to gluten and wheat tended to have glutamic acid decarboxylase and Purkinje cell antibodies. So that association between the antibodies in antibodies in the bloodstream and antibodies to neurological tissue, if you have a disrupted blood-brain barrier, I think is really scary and really relevant.
Yeah, absolutely. Well, we do know that beta-glycoproteins found on the blood-brain barrier or in the blood-brain barrier are influenced by, for example, St. John's wort.
Mm-hmm.
Now, St. John's wort works by encouraging serotonin activity. So the limited studies, because there are no drugs that actually, I've forgotten where I was going with that.
St. John's wort, antibodies to neurological tissue.
I was about to make a criticism that I wanted not to make, but I'm going to have to make it now that I've started. That's where the problem lies. I think that a lack of research occurs because if we don't have a drug that can be utilized to restore or make people feel better, restore health and make people feel better, then the research isn't done.
No motivation.
And the chances of finding a research company that's going to go in and then command the funds necessary from pharmaceutical companies to try and make drugs that will influence the blood-brain barrier means that we have a lack of research. But that a lack of research doesn't necessarily mean a lack of evidence. So that's where I was going before I thought, well, I don't want to appear to be in any way insulting the work of the pharmaceutical companies, which is invaluable, because if we didn't have a lot of the drugs that we have, we might well end up with a lot more problems. But
absolutely,
I'm not convinced that medicine and healthcare in itself should be quite so pharmacologically based. And I think we've heard that. It was on BBC Health just this morning, BBC News on a health section this morning, where a study, which I haven't yet read, so I can't reference it, I'm afraid, but please have a look at BBC, that BBC Health page, where they were saying that we are now missing too much by not focusing on people having more than one condition at a time.
Yeah. What was the commentary?
Oh, it was a very small snippet on BBC Breakfast where they said that there's been a paper published where there is concerns that patients having more than one condition are not being thought of as this branch and underlying trunk, that we are focusing too much on one of the branches, one of the symptoms. So if somebody is having migraines and asthma, there is no real work or recognition that an underlying cause may be causing the both.
I mean, that's absolutely been my observation, you know, that, and also my experience as a patient in the system, that you know, I was looking into, for one of my patients the other day, I was looking, who has migraines and IBS and endometriosis. And of course, part of my job is to understand how those are connected, you know, how those are all actually branches of the same tree in her body. But she sees 3 separate consultants. And you know, the other experience that I think people have, and it's a frustration from the physician's end, and it's also a frustration from the patient's end, that you're allowed to ask one question, you know, you're allowed to come in with one problem. And that's all that they have time for in the clinical practice. So it's conventional medicine, I think, is very compartmentalized. It's everything is put into a silo and it's considered individual. But of course, we know, you know, and as the functional medicine thinking, I think, becomes more popular, and it needs to, because chronic illness demands it. You know, you can't really think about chronic illness in such a in such a narrow, divided way and be successful with your interventions, because the leg bone is connected to the knee bone.
Yeah, absolutely right.
We learned that in kindergarten.
Before we move off, I see that we've had a question about the blood-brain barrier.
Yeah.
And how do we know whether it's disrupted? That's a very tricky one, if I can answer that before we move on. To know it from a clinical point of view. What we can do is test for it. There are certain proteins that shouldn't be found in the bloodstream, and if they are there, that means the blood-brain barrier is disruptive. And I think that by people becoming, practitioners and the public becoming more aware of the option of a blood-brain barrier issue, then in those that are not finding resolution through the initial steps of treatment, then we may well find that a blood-brain barrier investigation is of benefit, because then we can go to work on trying to fix that.
So I think, just to bring it back to your point as well, the first place you take that though is to the history. You know, you look through their history and you consider, did they have a car accident when they were 18 where they were rear-ended and they had a concussion? Do they do boxing as a sport or a hobby? You know, are there things in there? Did they have a knock on the head at any point? Have they done a contact sport? You know, are there things in there that might suggest that were they using, did they have any medical intervention that might have had an impact on the, you know, on the blood-brain barrier?
Yeah.
But at that point, you have to sort of ask, has it persisted? And then think about doing investigations. But in the absence of any indication in the history, then, as you say, there are some tests that you can do. So Cyrex RA20 is a blood-brain barrier antibody panel. Is there anything else that you're using in your clinic?
No, that would certainly be my preference. Absolutely. Yeah.
And another thing though is that, you know, the blood-brain barrier, of course, is intricately connected to the gut, you know, to the gut wall. So there is zonulin, for example, in the blood-brain barrier. There are occludins and, you know, the same proteins that regulate the tight junctions in the blood-brain barrier are also regulating the tight junctions in the gut. So if you have an issue with zonulin overproduction and you know, tight junction regulation in the gut, it's those same mechanisms, those same enzymes are also going to be upregulated in the blood-brain barrier. There's not a you know, there's not a cutoff point at the clavicle that says, okay, this mechanism stops here, don't go any further. If zonulin is upregulated, it's upregulated globally, not just in the gut wall. So you can make some inference to a certain extent, or you can make some inference from gut tests that you're doing as well.
Yes. Yes. Certainly. Another question has come up here on something we've mentioned. What are you going to say about St. John's Wort? As medical herbalist, I use it for neuroplastic stimulation and have seen significant effects on damaged nerves healing quicker than they otherwise would under the influence of Hypericum perforatum, I suspect. Was it perforated? Any comments? Well, I'm not a medical herbalist, so I think I would prefer to leave that to you. The evidence behind St. John's Wort and its use in healing damaged nerves is limited, and you can imagine why. We certainly don't imagine that pharmaceutical companies are going to put the money in to disprove that drugs are needed. So if St. John's Wort is working, it's going to be working and promoted pretty much on the back of what we see people benefiting, seeing how people benefit from it. Okay, so just to come back to our original train. So we've talked about blood-brain barrier. Lee, do you want to talk a little bit about the gut-brain axis, that information superhighway between the gut and the brain? Well, to a degree, I have, of course, by talking about the microbiome. But yes, the gut-brain axis, which can be read about in in thousands of studies just by clicking in Google, let alone going into PubMed or Google Scholar. The connection really is based on the amount of nervous tissue in both. They talk about 50% of the nervous system in the body is in the brain and the central nervous system, and the other 50% is in the gut. Now, if we've got that, and we know now that adrenal receptors or other receptors, neurotransmitter receptors in both and all areas of the nervous system respond to a particular neurotransmitter, we have to understand that if my tummy is upset, I'm going to trigger some form of adrenaline response, particularly if it's painful. So those with painful IBS symptoms may well be producing quite a bit of adrenaline from response from the gut nerves. That'll travel through the bloodstream, and in doing so, we're going to end up with the nervous system in the brain recognizing the adrenaline response. So we're going to get anxious. As we get more anxious, the nervous system in the brain is going to produce more adrenaline and adrenaline-like catecholamines to help us deal with whatever it is that the body is anxious about. That then travels down to the gut and makes the gut worse. So it's not so much an axis as a cycle or a circle. And it is remarkably quick how downwardly that spiral can go. Again, on that particular point, talking about the leaky gut, which we're not today, if we don't fix a leaky gut, if we don't fix the inflammatory response in the gut, if we don't get the tummy feeling better, we are very unlikely to get rid of emotional issues. So to not ask somebody about how their bowel is behaving when they have emotional issues is a missed opportunity. So the gut-brain axis, as I said, it's partly to do with the leaky gut, it's partly to do with the chemicals made and also broken down by the bowel flora. It is to do with the nervous system within one area influencing the nervous system in another.
Do you want to talk a little bit about thyroid and and emotions and thyroid and neurological health?
Yeah, absolutely. It's quite a quick comment, really, because the thyroid has so many effects on so many parts of the body that the influence that it has on neurotransmitter production is both direct and indirect. We are not going to have a healthy system in any part of our body if our thyroid function isn't right. Whether it's the thyroid that's not functioning correctly, or whether the thyroid receptors have been disrupted, whether they've been blocked by exogenous hormones, creating a thyroid receptor dysfunction, so many different options there. To not monitor the thyroid in persisting depression that doesn't have an obvious reactive component, I think is overlooking the issue as well. Again, another question, somebody has asked whether or not get the question up here in front of us. In the history of trauma, would somebody who was, say, bullied at school but is now happily married and has everything in place, is this a combination of exogenous and endogenous? Yes, I think so. Without a doubt, you can have both, but it's more likely to be that an unhappy childhood would have led to the nervous system creating too much in the way of an adrenaline response. It was safer and better for you to be adrenalized when you were younger because it got you out of trouble quicker. You recognized it quicker. You may have had to have hit back harder. It's all to do with adrenaline. But if your nervous system thinks that's what's correct, then as you get older, a small amount of adrenaline, everything's in place, and then you have a prang in the car. That small amount of adrenaline hits so many receptors that the brain thinks there's something really nasty going on. So it all, in my mind, that sort of situation where you've settled into a happier environment, it is more likely to have been a reactive problem that happened then that has led to a now endogenous depression. You may need to use medication, natural or otherwise, to get over it. So yeah, I think the thyroid comes into that as well. If we've had thyroid issues for many years, and many people have thyroid issues overlooked, mainly because we are so fixed on looking at results rather than listening to the history. If you've got a history of hypothyroid symptoms and you are borderline, you won't be treated. Sorry, borderline, the tests are borderline, you won't be treated. Wrong. Remembering that these borderlines are not normal. These aren't normal levels. These are reference ranges. They're population reference ranges. So somebody who's down here and is told is normal, they've spent their life up here, then that drop is actually quite considerable. But you wouldn't know it just by doing the test. And then when you only look at thyroid stimulating hormone, you miss out there as well, because a thyroid stimulating hormone that's rising, that's still within the population reference range, means the person's hypothyroid. We need to listen more and rely on tests alone less. But you can't really get everything from the history. You do need the tests doing.
So how do you actually assess if there is need for physiological intervention? What are you doing in your practice?
Okay, well, this is really the $64 question, and for those listening, I hope this is the really salient part of it all. I use analogies of a swimming pool, diving in the deep end, getting in the shallow end, and I use one of a step ladder, because we should always start at the bottom. And to me, putting people onto a drug is very much the top rung of the ladder. So history, looking at the history in the depth that we keep going back to, is so important. We have to optimize the 4 pillars of health. You've got to optimize your nutrition and your diet. If you don't, you're going to be deficient. You're not going to make your neurotransmitters. We have to look at our exercise program. If we don't exercise properly, we don't burn up our catecholamines and our adrenaline. We don't produce our happy juices at the same rate. We don't make our endorphins, our natural opiates, which are so important to our feeling of well-being. That's why people like exercise. And those of us that don't like exercise have actually just trained ourselves not to. We are better, happier, and safer if we exercise. We have to make sure our lifestyle is good. You're not going to be happy if you're taking in what you think are relaxants, but are in fact depressants or excitatory compounds. So we feel happier for having a couple of cigarettes. No, you're depressing the nervous system. We feel happier for our gin and tonic at the end of the day, or our pint of beer. Yeah, okay, but you're stimulating a whole raft of enzymes to break down the alcohol that are going to be busily breaking down a lot of your neurotransmitters. We've got to make sure our lifestyle is correct. We then have to cover that psychotherapeutic bit again. Look at what you're doing. Are you religious? Are you praying? Are you meditating? Are you spending time in rest and relaxation? Are you out with nature? Are you doing CBT? Are you using something like neuro-linguistic programming? If you aren't, and you know you've got problems, you're missing the point. We then come on to testing. And the testing is invaluable for those people where there isn't a simple answer. And to have a look at the blood-brain barrier, remarkably important. Let's have a look at the neurotransmitter levels. For those who want to go deeper, have a look at the actual compounds, the building blocks that make up the neurotransmitters. So rather than just looking at your serotonin and your neurotransmitter compounds, have a look at your tyramine levels, your tyrosine levels, your dopamine, which is a transmitter. Fine, but if you know what your tyrosine levels are and they're low, you may not be making your dopamine at the right rate. Without your tryptophan levels, you aren't getting your 5-HTP and your serotonin. Without your glutamine and your glutamate, you're not going to be making your GABA. And without GABA, you're definitely going to be out of balance, because it is an immensely powerful neurotransmitter for the brain.
So I've just popped an image up to sort of try to illustrate what you're talking about right now. The image is taken from the neuro-biogenic amines, which is a urine test to assess neurotransmitters and neurobiogenic amines. And one of the things that I actually really love so much about this test is that when you're looking at not just the the precursor level of the amino acid in the first place, but you're looking at metabolites of enzyme function along the pathway, you can actually trace it to a certain extent and to see which path that, which path that molecule is traveling down, by looking at which metabolites are high versus which ones are low. You can actually infer that. You can kind of trace it by the enzyme, right? So you can infer that perhaps monoamine oxidase A is underperforming, or that they're not methylating via COMT appropriately. And it's very similar to the testing that we use for looking at steroid hormones, for looking at, that conversion from cholesterol all the way through to estrogen and all of the different steps in between there. When you know which enzyme might be involved or is upregulated or downregulated, we have a really good knowledge of what are the nutritional cofactors required for that enzyme to support it. So monoamine oxidase A, for example, is supported by selenium. Tyrosine hydroxylase is supported with iron and BH4. So if that person is anemic, or if they've got SNPs in their methylation pathway that leads them not to be metabolizing folate particularly well, that might be affecting that enzyme. And we can start to put together the jigsaw puzzle to see how can we support nutritionally, how can we use supplements to improve or sort of potentiate the neurotransmitter pathways when there is a straightforward issue or a lifestyle related issue. Of course, we need to improve digestion and we need to improve inflammatory status, etc. But it's one of the very beautiful things about this test is that you're able to really see A to B, B to C, C to D, and when we can break it down in that way, you can see how to support it in a very specific way.
Are you able to show a test result?
Sure, I'll just have to flick through them. Oh, there we go. So that's the comprehensive. Yeah. I should really show them side by side so that you can track them through the pathways, but this is the comprehensive neurobiogenic amines, and then we have the more simple version, which is just looking at more so at the end stage metabolites.
Well, if you can flick back to the first one there.
This one?
Now that is invaluable to a practitioner who has the knowledge that you guys have in your training, because of course that is how you can govern both diet and supplemental choice. The neurotransmitter results that Regeneris are able to provide are more useful to me, I find, with a patient. Because whilst this is very useful for me, putting that in front of a patient is not all that clear. But when a patient actually sees that their serotonin levels are low, or their noradrenaline or adrenaline levels are high, and also on the same results sheet are able to see which natural compounds may be useful, and that includes things like vitamin B6 and magnesium, of course, as well as certain herbal options, I think it's an invaluable test. So both of these, the neurobiogenic amines and the neurotransmitter tests, are, I think, absolutely first class. So here, yes, where you're looking at serotonin, dopamine, the histamines and the glutamates, fantastic. Because where here in this example that you put up there, there's that serotonin touching that lower 2.5 percentile. That's markedly abnormal. So when somebody says, I'm feeling depressed, yes, yes, you are. And here is a result that shows this is not something you're imagining. You may or may not need the psychotherapy because this started at a point where you have got stuck. But look, we can help you here because we know how to get your nervous system to make more serotonin. We know how to replace serotonin if necessary. So yeah, these are two, I think, invaluable tests. Also, of course, is the recognition of your cortisol levels. Simple adrenal stress profiling. Oh, thank you. Yes, there we go.
I've got two here. There's one that's suboptimal and one that is Markedly abnormal.
Markedly, yeah. So there we go. We should be expecting our cortisol levels to be nice and high through the morning, ready for our use of adrenaline through the day. We want to have something that will stop us being overly frightened when that lion is outside the cave door. We then want to go through the day using it up, so that as the adrenaline levels drop through the day and the cortisol levels will go with it. Okay, this is somebody who markedly needs some support for their adrenal phase. And if that works, if we can get that working better, we're going to find an improvement.
This is not, I mean, looking at that test result, that's not a person that I would expect to have a lot of motivation. That's not a person that I would have to expect to have a lot of excitement necessarily. I mean, if they have a job that they really love and they've sort of gotten themselves into a state of exhaustion because they are so excited to jump out of bed every morning and they're racing through the day at 100 miles an hour, it's been 10 years. You know, they're probably going to have a slightly different insight on it than me, but I would expect that even in that person is going to have a remarkably less level of happiness and excitement over the happy stimuli than they would have 10 years ago.
Indeed, indeed. So I think these are, again, invaluable. We don't need, and I think this is done too often perhaps, we don't need to do this adrenal stress testing to tell somebody that they're stressed or not. They know that. But where these tests become invaluable is recognition for us of how low can you go. Because when you're about to drop into the blue level, you're not going to handle even the smallest of problems. And that requires much more interventional testing than perhaps somebody with a brave face will actually manage to transmit through the history. So once again, I think it's invaluable to do that sort of testing. That doesn't mean that other tests aren't of use as well. The cortisol, of course, as we know, and I think you flicked through a picture there when I asked you to put something up, showing the steroidogenic pathways. And for those who aren't completely au fait with this, we have at the top cholesterol, that terrible, terrible compound, of course, which we must all get rid of, transporting itself down to progesterone. And then if we take a right, as I'm looking at the screen, from progesterone into 17-hydroxyprogesterone and travel down there to cortisol. So if we don't have a good level of progesterone, we aren't going to make cortisol. If we are overly stressed for a long time, if we're chronically stressed and we demand more cortisol, we're going to drop our progesterone levels. If we drop our progesterone levels, the estrogen, which is being made through other pathways, will become dominant. Doesn't mean we have too much estrogen, but we do start to struggle with estrogen dominance. If we have estrogen dominance, as I said earlier, it's an excitatory hormone. That's going to make the nervous system more excited. If we're then going to use up our neurotransmitters to calm ourselves down, we're going to have less of those to counteract the adrenaline. Therefore, we're going to need more cortisol. And once again, we're caught in this downward spiral with a lack of progesterone. And interestingly, therefore, a small amount of progesterone, both male and female, but predominantly for females because they have more progesterone receptors. They will respond to a small amount of bioidentical and natural progesterone remarkably well. And of course, it's the estrogen progesterone issue that is very important, but not by any means entirely the cause of premenstrual tension. And as we all know, some ladies can struggle for 2 weeks coming up to a period. Others won't have a problem at all. Without knowing what progesterone and cortisol levels are doing and what the balances are, we don't necessarily have the right course of treatment. And we can spend a lot of time with counselors and a lot of time on diet and exercise, and all we need to do is try and re-establish the progesterone balance. So for doctors who might be able to prescribe progesterone, bioidentical preferably, that's fine. But pregnenolone is certainly something that can be considered by nutritionists, I believe, although I don't absolutely support that if they don't have training in this pathway.
Double check with your governing body before you go down that pathway, please, everybody.
Yeah. So, but again, there are doctors like me around, and if a practitioner feels that progesterone or pregnenolone might be of use and they don't feel comfortable about prescribing, run it through a doctor. Get the patient to have a session, one session with a functional medicine doctor, and you've got every right to carry on a prescription once it's there, I'm sure.
Mm-hmm. So I feel like I interrupted you in the middle of the ladder analogy.
Well, no, we were
this pathway of testing, which of course I could talk about for another hour, but
okay, you're quite right. Our time is up, isn't it? So, having recognised either from the history or from the history and testing, and preferably both, mm-hmm. I think we then move on to what the treatments are, and that depends on what we found. From the diet history, are people obviously lacking in certain things? I think vegans and vegetarians who aren't well trained or haven't had at least a session or two with a practitioner to establish their requirements, then amino acid deficiency from protein deficiency is very possible. So making sure the diet is right, bringing in the right supplements would be the next step up the ladder. Thereafter, we have to look at the herbal therapies. Can we bring into play St. John's wort? Are there other components in herbal medicine? There are a lot of adaptogens out there, ranging from the ashwagandhas and the rhodiolas through. And again, I comment on this as an enthusiastic amateur, rather than with letters after my name to say that I should be commenting on herbal medicine. But we can read about these things clearly, and we can prescribe accurately, I think, without any downside. Then we need to talk about drugs, and I think then, only then, we need to talk about drugs. And if we're still struggling, then of course it is off to the psychiatrists. But I don't think this conversation is about schizophrenia and psychosis. This is more.
Unfortunately, no. We might have to get you back in to talk about that, because it's so interesting when you do. But I think that we need another hour just for that subject in and of itself. So, but at that point, drugs are appropriate. You know, that's an appropriate intervention. And one of the things that I feel is misunderstood a little bit about functional medicine, or perhaps nutritional therapy, is that they are anti-drug. But I think that medicine, like prescription, you said before that you feel medicine is perhaps overly dependent on the pharmaceutical side of things, which of course I actually totally agree with. But medicine is important, you know, to be used appropriately is such a critical, important part of healthcare. But appropriate medicine, I mean, appropriate pharmacological intervention is the lowest dose for the shortest amount of time to get you from A to B, and as opposed to it being the only option presented to you, and that you're on it forever if that's not ultimately necessary.
Indeed. And I think that that's a big failing, isn't it? Because so many people end up, start at the end.
Yeah.
They walk into their GP, and all too soon, mainly through a lack of training at medical school and a lack of determination by continual education in the medical field to look at other options, we end up too swiftly on drugs.
And you know, another observation of mine about your ladder is that while nutrition is one of the actual rungs on the ladder, that nutrition and nutritional biochemistry affect every other rung on the ladder. You know, that somebody who is well fed and nutrient replete is very likely to have a better response to a drug, you know, a drug intervention, than somebody who doesn't have enough probiotics, doesn't have enough B vitamins for that neurotransmission. You know, if you're forcing forcing neurotransmission. I'm going to say that. I feel like that's an inaccurate statement, but you know what I mean. If you're having a physical function forced via medicine, and you don't have the appropriate nutrition, the proteins and the cofactors in place, or you have inflammation that's creating problems with the receptors that are used in that process, you're going to have less of a desired outcome than somebody who's got adequate nutritional status in place.
Indeed.
So just because we are out of time, I'm going to try to recap what you said. So let me know if I've got any of this wrong. So here's a 1 minute recap of the entire webinar. So one of the critical, most important first things that you need to do is to take a thorough history. That 90% of the information that you're going to receive, about 90% of the diagnosis comes from the history in and of itself. From there, we're starting to look at what are the exogenous and what are the endogenous underlying factors. And we are referring out where necessary for alternative therapies, for talking therapy or passive kinetic therapies that will help to support well-being in that person. When we identify that there is something endogenous at play or endogenous support is needed, then we're considering what are the things that are required for healthy emotional pathways and neurotransmission, and we're looking at what are the things in the body that are having an influence, such as hormones. So we're considering the neurotransmitters themselves. Are we making neurotransmitters? Are we transporting them appropriately? Are we metabolizing them effectively? We're considering estrogen, progesterone, and testosterone. We're thinking about the gut microbiome and perhaps the vagus nerve and that gut-brain axis. We're considering the blood-brain barrier. We're thinking about leaky gut, also as it pertains to the microbiome and the blood-brain barrier. We are thinking about toxins and liver function, which again, you have mentioned, but we probably need another hour webinar to discuss in depth. We're thinking about thyroid. We're considering whether or not this person needs to be assessed for thyroid intervention. And actually, is that it? And we're assessing nutritional status.
Yes, I think that is a very, very comfortable summation. I would add
listening.
Two things.
Mm-hmm.
Neither of them to do with that ladder, really. One is a big thank you to Shireen, who has said that hashtag multimorbidity is going to lead to the reference of the issue about integrating our medical practice. Well, if we can get that through to the concept of conventional medicine, that would be great. I do know that His Royal Highness Prince Charles and Prime Minister Modi from India yesterday opened an Ayurvedic centre in, I think it's St. Charles Hospital in Kensington. Wow, they're really impressive, because this is going to talk much more about the Ayurvedic principles, which is really what we've been talking about. Looking at the person as a whole and starting at the root basis, moving up. And that's lifestyle, exercise, dietetics, being well in yourself, psychospiritually, and then looking at the advantage of treatment. Treatment, without doubt, will benefit from the testing so that the practitioner can help guide, because otherwise you can spend months taking something that's not actually relevant. And knowing what we are dealing with is so much easier and better for an individual patient. We are, of course, caught to a degree in the private sector, and tests come at a cost. But I've had so many people who have spent so much money on completely the wrong stuff because we're not aware of what we should be prescribing. And the second is, I must apologize for the wobble on my camera. We have workmen next door, and there's a terrible row. So I've actually had to come into a room where the table and the floors are, if I've moved, the cameras wobble. So I do apologize if I've seemed a little bit shaken. I assure you, my advice is sound, even if my stability may not appear so. Thank you, Robyn.
Thank you very much. Listen, thanks so much for your time today, Dr. Sharma. So I've got 2 more questions. We are being asked a little bit more information about the biogenic amine tests. Are they accurate? Are there any potential disruptors? I would be more than happy to send out any further information on the biogenic amines. They are very accurate. Dr. Stader, who runs neurobiogenic amines, have invested a lot of effort into making sure that this is a very high quality test with good science backing it up. So I'd be more than happy to share that info. Can I repeat the reference for the 2015 paper? So that was Vojdani and Karazian for 2015. I can't remember the actual journal that it was in, but I do have a copy of the paper. So I'll send it to Lauren and it can be sent out to anybody who would like it. And the hashtag was #multimorbidity. So unless there are any final questions, I think that brings us to the end of our presentation today. Thank you so much, Dr. Sharma. It's been such a fun time walking through this.
Thank you, Robyn.
Of course, my idea of fun.
Generous. And thank all the participants who've been listening.
Thank you for joining us at home, and hello to everybody who's watching this on the recording at a later date. I hope that you are in the sun listening to us and having a cocktail or a non-alcoholic cocktail over the weekend. All right, thanks everybody. We'll see you at the next webinar.
Take good care. Bye-bye.
Bye-bye.